6, 5.
Well, welcome back after the break. And in this section, we're going to be looking at primary care, health creation, and the role of social prescribing. And we had this very elevating talk by Sir Michael Marmot earlier, where he emphasised the importance of both primary care and social prescribing in terms of the inequalities that he was talking about. And then in that second section, and I think Ian, our first speaker, will be delighted to hear about it, there was much talk about progressive primary care networks and the role that they're doing in making the change. Now, Sam Everington is going to be co-chairing with me. He's the one that's going to be looking at the questions coming in and making sure that we put the right questions to our speakers. But without more ado, I'd like to introduce our first speaker, who is an old friend. I think I first met him when he was the Prime Minister's Special Advisor. He's always been supremely flexible and open when it comes to public debate of this kind that we're having today. But more than anything, and I want to put this on record today, Ian Dodge, without you, Ian, I don't think social prescribing would have happened in the way it has. He has been the supreme champion on high to make it happen. And if there's one person that we need to thank for social prescription being public policy and implementation today, it's you, Ian. Over to Sam.
Yeah, Ian, I just want to say a very big thank you. I know you're sort of leaving NHS England. We don't quite know where you're going to land up, but we so hope it's going to be somewhere in the health service. We really don't want to lose your amazing talents. I just want to express my big personal and thanks from all the social prescribing movement, from Bromley by Bow and all the centres around both England, UK and international, because I think most people don't realise the key role you played in taking social prescribing from small projects, a network in the country, to something now that is effectively in every general practice and will absolutely transform the way that we approach patients, focusing on them, what matters to them, not what the matter is with them. And that's dramatic. That is dramatic in terms of the impact that's going to have on patient care, because immediately you massively expand what we can prescribe as clinicians in the NHS, and that the end product effect outcome on patients is just so enormous. So this is my chance to say publicly a very, very big thank you from all the social prescribing movement.
Well, look, thank you so much, Michael and Sam, for those really kind words. And at the risk of this turning into a kind of mutual backslapping session, I first came across social prescribing thanks to Sam almost 20 years ago, exactly in 2002, when I first visited Bromley by Bow, I think with Rob Webster at the time, who now leads one of our most advanced ICSs, and was blown away by the way in which you were reinventing what general practice has been doing. And Michael, your leadership, I think we had the conversation when you first became NHS England's kind of national clinical champion for social prescribing. You've been at the vanguard of this for many, many years as well. I mean, the first comment I'd make is I live in Kentish Town, and I'm a member of the James Wigg practice. And Kentish Town general practice has historically a really important part in the role of general practice. If you look at huge figures like Hugh Faulkner, Dr. John Forder, who then became the chair of the RCGP, they recognised the importance of expert generalism, and they recognised the importance of wider social determinants and the need to connect up general practice services actually with those wider community services, because that's how patients were presenting. That was the nature of the challenges that they faced. And they represent, I think, an incredibly powerful and continual strand of general practice, which has emphasised the psychosocial aspects of general practice alongside the biomedical. And social prescribing, I think, is just the blossoming of that latent strand. And both are important together. One only has to look at the excess mortality in the last couple of years as a result of COVID. If you take things like CVD, unpublished data shows a big spike in excess mortality, some of which will be because general practice has been busy doing other things like vaccinating the nation brilliantly, rather than some of the chronic disease management indicators in the QOF. And we clearly need to try and make sure that we get the balance right across both aspects. My first message to colleagues today is that, and it's quite a bold statement and one I've never made before about probably almost any other policy, because I've spent too much time with senior leaders and particularly politicians who for noble reasons will declare that their latest particular policy or programme is irreversible. And I've always thought that there was a dangerous element of hubris in such statements. But as I was thinking about this session, I actually think it is genuinely the case, not quite uniquely, but more than almost any other area I've worked in, to say that I believe that social prescribing and the progress we've made is now irreversible. And the reason why I think that is the case is because, one, there is a huge groundswell of energy behind this, from patients, from communities, and indeed from clinicians within the NHS, as well as obviously the social prescribers. This is unpublished data, but we are ahead of schedule in delivering against the 26,000 people coming in through additional roles. There's some published incomplete data. We have the NHS England estimate of the number of people recruited into roles as of the end of December is over 16,000, which is ahead of our 15,600 goal for the end of this financial year, of whom over 2,000 FTEs, social prescribers, have now been recruited into primary care networks. And that number will continue to grow. Those of you who may have watched the debates about the future of general practice and the lively debates about whether GMS, whether PCNs, let me reassure colleagues, one, PCNs will only go from strength to strength, not least given the forthcoming conclusions and actions arising from Dr. Claire Fuller's review, which has been commissioned by Amanda Pritchard, our chief executive, but also because the PCN DES, which provides the funding for the additional role scheme, people sometimes forget that the GMS contract continues until it is changed. And so a default position is, even if there is no consensus around change, the £1.4 billion that is locked up available for additional roles actually will by default roll forward rather than fall, because it's a 5-year framework for contractual change. It's not a 5-year contract that falls come 31st of March 2024. So the funding will be secure, and PCNs, I think, will absolutely continue and go from strength to strength. And the final reason why I think social prescribing is irreversible is because there is also a very clear political consensus. So it's not just the current Secretary of State, who I thought was fantastically enthusiastic about personalisation and social prescribing in his speech earlier this week, or indeed his predecessor, Matt Hancock, who helped establish the National Academy of Social Prescribing and gave it cash, or indeed Jeremy Hunt or predecessor secretaries of states, all of whom have embraced and supported social prescribing, it is that there is a cross-party consensus. If you look at, say, the people who are supporting the National Academy, there is a coalition across all political parties to support what you're doing. So that's my first point. My second point, and my next set of comments, are really about the opportunities to go further and improve what we're already doing. So the second point I'll make is that part of the success of social prescribing is what the NHS and social prescribers can connect people to. How well is the asset base of local communities, voluntary and community organisations, how well is that being stimulated and supported? And that is a critical role for the partnership, the integrated care partnership between the NHS and new statutory integrated care boards and local government. It is a critical role. It's not something the NHS can itself purely lead on. It is about supporting local communities, and our continued champion of this. And actually social prescribing provides a brilliant case because it provides a referral and some of the demand numbers as to why wider public investment and voluntary sector investment is necessary in so many of these other non-statutory services. So that's a huge and important agenda that can only be delivered by NHS with VCSE and critically convened by local government. My third point is, and look, this ought to be axiomatic if you think of the term social prescribing link worker, the link, the sense of connection is key. But what's really critical, and we'll hear some fantastic examples of this later in the session, is how do we best ensure that we don't just embed social prescribing within the activities of all of the individuals working in a wider primary care team, but actually there is a clear and conscious design as to how across PCNs they are connected together, and indeed with other services as ICSs get upstream around proactive anticipatory care for people with our most complex needs. And that will include, as Michael Marmot was passionately and eloquently demonstrating this morning, people particularly from our most deprived communities and from particular BAME heritage groups, but not exclusively. So there's a key role in most systems still about how do we best get those connections right, including to new services that are about anticipation that are not fully embedded. My fourth point I'd make, and this series of comments is really about integration, is if you think from a patient perspective about their needs, you wouldn't just think about primary care. Primary care is the obvious place to start and embed social prescribing, because that is where the vast number of contacts come from. The 350 million appointments last year, including vaccinations, over 20 to 1 compared to A&E type 1 attendances. But we have people that also present or are engaged with the NHS in our mental health providers and in our acute providers and our specialist services. And what is an ICS? Where did it come from? In part, the idea that population health management is too important a job to be left just to commissioners. We need to leverage the support and engagement of all of our providers, including our acute colleagues and people running trusts. And there is, I think, a profound strategic opportunity for how ICSs can engage particularly new provider collaboratives in other sectors about thinking of how do you get the connections right around social prescribing, linked to the integrated care record, and thinking much more seamlessly about patients and services rather than sectors. That's my fourth point. My final three comments are really about how do we improve what we're already doing. So it's great that we've made progress on capacity and recruitment, and there was a notional goal of 900,000 contacts by 2024, which we've almost already achieved because it was over 800,000 kind of last year. However, if you were to look at the data, and people don't have this readily available, but look at the data about, is this a fully have we reached a fully comprehensive universal service with endpoint achievement of that? Do we have consistency of availability of social prescribing and volumes according to need in all parts of, just within practice teams, across practices, across PCNs, across all parts of the country? And the answer to that is absolutely not. There is an extraordinary variation and a massive job to be done about dealing with the internal spread and continuing to win hearts and minds about the further rollout of social prescribing. And at the heart of that hearts and minds, because there will be skeptics, there will be colleagues who are less enthusiastic because they're incredibly busy doing lots of other things. And at the heart of that is an urgent need, and this is particularly nationally rather than locally, but we must end up making further progress on establishing a clearer, quantified evidence base beyond some of the local studies and the brilliant, inspiring stories about the quantified benefits of social prescribing, not least given the investment, the different buckets. What are the effects? How can we get to published peer-reviewed evidence around impacts on avoiding repeat GP appointments, on prescribing medicines, prescribing levels, on A&E attendance, on admissions? How can we be much clearer actually about what the impacts are? Because it's partly by having the evidence base that we can convince skeptics and indeed funders that actually social prescribing is the expansion of it is the right decision to make, bearing in mind the opportunity cost of doing other things. And then my final point is around how we continue to learn together and optimize. And look, there is a magic in what social prescribers do at their best. The emotional intelligence that is brought and the effect that people lead on people's lives, which cannot be readily kind of counted in a way I was just implying. But there will be learning about caseload, about tactics, about optimal operating models, about ways of running the service, where we can do, I think, a lot more about spreading that learning and helping with appropriate standardization of services that maintains that sense of personalization. And that opportunity is not just across within ICSs, but across the NHS as a whole. And increasingly, as the rest of the world pays attention to what's been going on here, how we learn from our international partners. Thank you very much.
Well, thank you, Ian, for a very far-ranging discussion, and I think your points about the future so well put. You know, and this balance we're going to have between standardisation and personalisation, letting all the flowers grow, but also making sure, and Michael Marmot pointed out earlier, as did Anand Charney, that there are inequalities both in the provision of social prescribing and also the uptake. Now, I'm sure Sam's been taking down a lot of questions, but I think what we'll do is ask the other three presenters to present and then come for a discussion at the end. So it's my great pleasure now to go over to Dave Sweeney, who's been like a frontline advocate and leader for social prescribing as Executive Director of Partnerships at Cheshire and Merseyside Health and Care Partnership. And he's speaking to us from far away. Dave.
Thank you, Michael, and thank you, Ian. It's a pleasure to be following such an inspirational speech. And the reason I am here speaking as I'm on holiday is the fact that I wouldn't miss being in the same panel as everybody else on this panel, for one, but two, because it is a movement. And when you're part of a movement, you make sacrifices, and everybody's got to do that, I think. And the fact that there's so many people on this, so many people in these attendees. I'm not going to talk about social prescribing because you're all experts, but it does need leadership, and it does need leadership. It does need commitment, and it does need a different style of leadership. As Ian very politely said, you will have skeptics. I'd probably use other words, but it's absolutely right. You're dealing with people who. On a regular basis, that I think those of us who are in social prescribing, or as I describe it, the kind of left field of the NHS, in that kind of marmot world, it's very difficult. It's very difficult. It can be frustrating and all the rest of it. So what I've done in Cheshire Merseyside, we built. I was never a fan. I've never been a fan of those who work with me. You'll know I'm not a real fan of detail and reporting and those kind of things, but over my career, kind of I started when I was a chief officer in Halton. We did extremely inspiring stuff, and that's where I met Michael and Sam and Merron and all these brilliant people. Really pushed the boundaries. It was a small area, but we did some really insightful stuff. And as I moved over to the ICS, I was in the really early stages of the ICS, so in the kind of first year of the growing of Cheshire Merseyside, which is a vast, enormous ICS. Was able to use that information and all that kind of knowledge to ensure that we never lost sight of that, the health inequalities and the areas of such importance. And I'm in a brilliant position as the Director of Partnerships, almost the Kofi Annan of the ICS, being able to install those real demonstrable social prescribing, personalised care, social value, the environment, linked all these into a really neat portfolio with some amazing people that work with us. So I want to give a couple of examples just for kind of food for thought, really, in terms of and learning, because I know I've had a look at what Darin's been doing in Devon, and it's amazing, but it's so important that this doesn't become, through the new transition into ICS, it's just another bit of tinsel on the tree. We have to embed this right into the heart and soul of the ICS. So Ian mentioned about the voluntary section of the community assets, and again, from a social prescribing perspective, if you lose that, if there's a referral made into our communities and that community asset has either folded or not been supported, you've lost so much in that. The GP loses faith, the individual loses heart. It's so important that we keep those assets. So I've worked with our voluntary sector, all the VCS, all the VCSE, small to medium enterprise, and we pulled them all together into one memorandum of understanding, just a bit of policy, just a bit of something that ties around it. And we asked for a leader for the VCS section, a chief executive in Cheshire and a chief executive in Merseyside, to come together, sit in our partnership board, so sit right in the heart of the partnership board, the mechanics of the ICS. And from then we've built this real momentum going forward, where not now is the voluntary sector just a piece of an advert or someone who comes in to put a bit of tinsel on it. Part and parcel of that part and parcel of the work that's going forward. So we're now at the point where we're transitioning the voluntary sector into its own transformational board. So the voluntary sector, as Ian again has said, to give some standardisation, to give some real levelling up, I'm going to use that term, levelling up across the voluntary sector under this transformational panel. So it sits alongside cancer, sits alongside mental health, sits alongside our CVD board, right in the heart of that, so it gives it that importance. I just want to give you another example. So another example is, as a partnership director, my job is to bring partners in, and it doesn't matter who they are and where they are. And one thing I'll say about social prescribing, people work in social prescribing, there's very few parochial individuals. People want to learn and share and use their experience, and will pinch with pride from other areas that are doing some great stuff. And I think that's remarkable in the NHS. There's a lot of that silo working. So we approached our housing association, and the big ones right across Cheshire Merseyside, brought them all together. And we asked the question again around social prescribing. What can we do as a partner? What can we do? We're at the point now where we're hitting into our hardest demographic areas and building up a proposal to ensure that so Michael Marmot talks about those hard demographic areas, we can pull people out of that into a pathway of work through our social prescribing academy, into PCNs, into health and social care, fill the gap from our workforce depletion, but also pull people out of that poverty. Really, really exciting stuff. That would not have happened if we hadn't got the evidence, and as Ian said, the data around what social prescribing can do. You know, massive piece of work. I'm going to finish on some hooks. I love hooks. There is no board. Let me tell you, and this is absolute fact, there is no board in this land, right? Whether you're an acute trust, a big PCN, a local authority, someone in industry that doesn't want to be an anchor institute. Let's use FOMO, and I love it. I love that FOMO. It's a great leadership term. The fear of missing out. They all want to be anchor institutes. There's so much in that anchor stuff. So we can, if there's one thing we can standardise without having too much parochial kind of push or levelling down, is green plans. We need green. We need the environment to be green so we can socially prescribe that green. So let's say we need social value. So if you want to prove that you're a bigger institute, an acute trust, you want to prove that you are in the heart of your community for your social value, invest in social prescribing. Give back. So we're pulling all these kind of almost kind of criteria, which is gently hooking in more and more and more people. Just a very subtle, addition to what they can do. For somebody wants to be an anchor institute, for example. Have you thought about? Have you done this? Have you done that? So I'm really proud. Cheshire Merseyside do some brilliant stuff. It's not easy. We've got a huge amount of acute stuff going on. We've got 9 places. So my tip is, I'm going to leave, because you've some brilliant minds on this panel. Okay. So I think, just going on top of what Ian has been talking about, if we get to the point where the architecture of social prescribing is right in the heart of the ICSs, through governance and through commitment and through bigger and broader partnerships, and people that think differently and act differently than the NHS does, we're in a great place. I'm going to have to shoot off because I am on holiday. Bless you all. But I put my email and my Twitter handle in the chat. I'm sure Andre will share that. Have a fabulous day, and I would love to get in touch. Any bright ideas or brilliant stuff, please do get in touch. Always willing to learn and to share. Thank you very much.
Well, thank you, Dave, and thanks for making the sacrifice on your holiday. As you say, social prescribing does involve sacrifice, and I also thought your point was so true that social prescribing community is different from any other I've ever been in. There are no egos. We're about sharing. We're about creating, and it creates its own momentum, doesn't it, of goodwill? And I think you described that so well. But we're now going on to Merron Simpson, who in a way was my successor as chair of NHS Alliance, although she's polished it down and brushed it up, and it's now called the Health Creation Alliance. And over to you, Merron.
Thank you, Michael. And just to clarify, I'm the Chief Executive of the Health Creation Alliance, not the chair. So, but thank you for inviting me to speak today, and I'm delighted to be here. On a platform with you all at such an important conference, and I've learned such a lot already this morning. So it really is a rich event, and I'm very grateful to be here, being able to talk a little bit about primary care, health creation, and social prescribing. So the Health Creation Alliance, under its former name, the NHS Alliance, started work over 6 years ago to develop a framework and a movement for health creation. And today, the Health Creation Alliance is the leading national cross-sector movement addressing health inequalities through health creation. Our mission is to increase the number of years people live in good health in every community. And our ambition is for health creation to become business as usual across the health and care sectors and well beyond. As a cross-sector organisation, we have many housing members, for example, and health creation applies as much to them as to the health sector. So, looking at primary care, health creation and social prescribing, I'm going to say 4 things. And this slide is going to really come up as a focus later on in a couple of minutes. But first, what I want to say is that social prescribing is absolutely critical. There's no doubting it. Social prescribing has made a big difference, huge difference for patients, for general practice, and for communities. They've enabled a whole range of different non-medical remedies to health issues to come into play. And I've seen its evolution over the last few years, and I've been impressed. And my sense is that particularly in places where primary care is working closely with the VCSE sector, where link workers are close to communities and working in partnership with them, it has been a huge success. And its strength and success is based on it being a patient caseworker and those making those connections across the system. So the question of how it might evolve from here is a really important one. And the second thing that I want to say is that the problem we're trying to solve is very, very big, and it's just got bigger. And we've already heard from Professor Sir Michael Marmot today, so I won't say much about that, but poor health and large health inequalities going into the pandemic, poorer health and larger health inequalities of many types coming out of that. In the words of one GP that contributed to one of our research projects from Sheffield, she said, it's difficult to put the resources where the worst problems are because they're everywhere. So added to this, we've got the problem that the current model for primary care is not sustainable, and that is one of the early findings coming out of the fuller stocktake for primary care. So health inequalities is a tsunami, and social prescribing can help hugely with that. But a problem of this size, I would say, cannot be solved by link workers alone. It requires a more fundamental change in how we all work. So thank you. The slide now is the right time, because part of that fundamental change that's needed is what we call health creation. So if you wouldn't mind putting that slide up now. So health creation is everyone's job. I don't know if the slide's going to come up, but essentially building meaningful and constructive contact between people and within communities increases their confidence, and that leads to greater control over their lives and the determinants of health. And it's having that control that helps make people well. We call this the 3 C's: connecting, building confidence, and having control. People need also, in addition to that, an adequate income, a suitable home, an engaging occupation, and a meaningful future. And of course, this access to the wider determinants of health can only happen when local partners are working together in a concerted way to achieve that. And we identified 6 features. We call them the features of health creating practices. And we did this by talking over a number of months and years, actually, to people who had experienced living in a community whose health had improved. And what we asked them was, what was it that made the biggest difference to you in that improvement process? And they told us there were 6 things, and that is listening and responding, truth telling, focus on strengths and what communities can do, self-organising and helping people to connect with their purpose, power shifting or power sharing, and reciprocity is the last one that we've added recently, actually, being able to give as well as get and get as well as give. These are really important to communities, and they told us this, and so we've hung on to those, and we want to we've built a framework around that. They're the active ingredients in health creation at the front line, and they're essentially drawn from what works best in community development. So if our collective efforts to reduce health inequalities are to be sustained in the long term, then health creation must become central to how we do things, and in social prescribing and across the whole system. So the 6 features that I've just mentioned and that are in that slide, they can help to inform how all these sectors work to create health? And what if all the frontline roles across the NHS, local authorities, housing, and far beyond that were to use them to develop new practices and skills and embed them in how they work day to day, alongside their specific skill set relating to their professional role? So making these features of health creating practices universal at the front line is one way to start to build this into a system and to start to rework the system around them and to design and enable communities to take control and create health. So the fourth thing that I want to say is that in addition to these frontline roles, we need a health creation ecosystem and infrastructure built around this. And I'm going to illustrate this with figures from the Citizens Advice Bureau that I heard not long ago. And apparently demand for Citizens Advice Bureau services has increased 500% due to social prescribing. So what should we do with that information? Should the government increase resources for Citizens Advice Bureaus? Well, yes, they should. But how can we possibly increase them enough to deal with that kind of demand? You see, Citizens Advice Bureaus are in pretty much the same place as the NHS, hugely increased waiting lists and no prospect of sufficient funding to meet that need. Or do we lobby government to change the policies that are creating these problems? Well, yes, of course, that's part of the solution. And we would love NHS providers to increase their lobbying on the social determinants of health and many of those things that are raised in that Levelling Up white paper in those missions. Or do we work as equal partners with communities and place-based partners to identify the root causes of these sort of problems and do the hard work of building new solutions and new pathways that perhaps are social pathways together? And yes, I'd say that is also a significant part of the way forward, because communities themselves are highly capable of coming up with new solutions and driving them forward. They need both funding to be devolved, and they also need organisations around them to help provide the infrastructure for many of those solutions to take root and to strengthen. So we need to build the infrastructure around them to make sure that they actually become part of the solution in a sustainable way. So integrated care systems are now bringing together a wide range of partners operating within their geographies through the integrated care partnerships. And it is absolutely critical that primary care networks connect and embrace cross-sector partnerships as well at the neighbourhood level. And I'm delighted to hear about the progressive partnerships that we've heard about this morning. So this would make it possible to build that health creation infrastructure around social prescribing. And that is really badly needed. So coming towards the end, what is the social prescriber's role in all of this? Well, as I've said before, social prescribers are hugely well placed to support that shift in health creation. They can adopt the 6 features of health creating practices in their work. Many already do that, and where they do that, it's really making a difference to people's lives. They can support the development of relationships and community partners, and some already do that as well. They can advocate for their clients in multi-agency partnerships. They can support the emergence of new, perhaps social pathways is a word we might use, for people to improve their health. They can do many things, probably much more than I've said here. But there is a danger that we place perhaps too great an expectation on that single role. And I think that it would be a huge mistake to expect link workers to do all this, to do all the work. In fact, it would probably be an abrogation of responsibility. Social prescribers are patient caseworkers. That's part of their success, and that's a critical role they perform. Adding in community strengthening, community building to their job description, expecting them to work with communities on new solutions. This is intensive community-facing work, and it takes time and requires a particular skill set. Fitting them around a patient caseload is, in many cases, just not possible in the right level that it needs to happen, the right volume. And requiring social prescribers to be the principal relationship builders to the wider system, as it is changing, is also unsustainable. So I'll finish with a quote from a senior local authority leader who contributed to one of our research projects recently. And he was talking about the difficulties of connecting the local authority and what they're doing there to build this infrastructure to the NHS. And he said, the DES contract has put the operational level in. The social prescribing link worker is that connector. But the strategic role, there's a gap between the clinical director and the strategic level. Now, that is just one of the gaps that primary care still needs to fill as we embrace health creation. And I'd be more than happy to explain a little bit more about how the work we've been doing to talk about how that gap might be filled, one of the ways, although I know that there's a lot of innovation going on in that area. So I'm looking forward to the conversation later. So thank you.
Well, thank you very much, Merron. And I think you described very well this ripple effect of social prescribing and how it changes the conversation locally and how it creates a changed ecosystem, which is incredibly important. And then we can build upon that to improve local health in the way you describe. Our last speaker is Darin Halifax. And Darin, Darin's extraordinary because he virtually leads the voluntary care sector in Devon, particularly around social prescribing. And we were talking about ICS just now, and Darin's really put the question to myself as chair of his committee and others: how do you actually embed social prescribing in an ICS and create horizontal and vertical connections that Ian was talking about? And Darin, look forward to hearing what you're going to say.
That's very, very kind of you, Michael. Thank you. Hi, everyone. Darin, as Michael said, Darin Halifax. I'm the Devon Integrated Care System lead for the voluntary and community and social enterprise sector. And I'm also the lead for social prescription. And really what I wanted to talk about today is the tale of Devon and its relationship with the wider third sector, the wider voluntary community sector, as a foundation for better health and happiness, because that's what we're all here to do. And what that means for great social prescription and what that means for having a really effective progressive ICS. And I think there's two things I really want to major on. One is it's about time, taking time to build those relationships. Relationships are the key of everything across so many different levels. It's incredibly complex, but it's all based on having that honesty and that credibility in having conversations that matter across the piece. And the second thing I want to allude to what Ian said earlier, I think I'll start with a quote from a social prescriber in Devon who said, the social prescribing system we have is we've got an awful lot of travel agents. We don't sometimes have an awful lot of holidays. And I think that's really, really important. I think we've got a fantastic embedded workforce in Devon. What we've also got, what you need is you need the yin and the yang. You need that fantastic workforce, and you need the things that people can refer to. And I guess what I'm going to be talking about today is that second yang bit, because we've already got the yin sorted out. That's incredible. 66 workers at least in Devon, and probably increasing as I speak. But we need to make sure that their work is rewarded with having a secure base in the community for them to refer into. So Khadija, I don't know if you've got my slides ready, or if not, I can do it from here. I'll do it from here. That's probably easier, isn't it?
I haven't. Sorry.
No, okay, I'll do it from here. Okay, leave it with me. So give me a sec.
Okay.
Right, tell me when you can see this. Hopefully it's all come through.
Yeah.
Yeah, good. So how the VCSE is making its mark on the ICS and in social prescription. So let me just give you a bit of a whistle-stop tour across the county in terms of the voluntary community sector, but also I'll talk about the PCN makeup as well. Around 7,000 organisations, big, small, huge charities with multi-million-pound turnover, ranging to 2 people working out of a shed in the back of Crediton, for example. So massively diverse, all performing amazing things in communities. And we have almost twice as many registered charities compared to the national average in Devon. And I think that reflects the geography of the county. It's sprawling, it's got a couple of cities, but it's mostly made up of market towns, coastal towns, villages, and is predominantly rural. The VCSE employs about 5% of Devon's working population. And we tried last year to work out how many volunteers we've got in Devon. It's almost an impossible task, but we reckon formal volunteering 59,000 around. That's a very distinct figure, isn't it? 59,000. I don't know where we got to that. I could have said around 60,000. Could have been a lot easier. But also, if you think about the volunteering that happened around COVID, that is nowhere near the numbers of people who contributed daily to active lives in their communities. But if we talk about formal volunteer hours alone, around about 115,000 hours a week, and that equates to an annual value of £74 million. So it's a big hitter. The voluntary and community sector enterprise sector in Devon is a big hitter, and this is reflected nationally as well. And then if we talk about our PCNs, we have 31 PCNs in Devon. All of them employ a social prescription worker, at least one, and in total we have around 66, all with different titles: social prescriber, link worker, community connector, health coaches, etc. So let me talk about the makeup really. So I've been in post for 2 years now, and why that's relatively important is my role was actually asked for by the voluntary and community sector to the STP as was then. We already had a pretty good relationship between the STP chairs and the exec and the voluntary and community sector, but they said they needed more. They wanted somebody who would champion the sector within the ICS. We knew what the ICS was coming. They wanted somebody to champion the sector within the ICS. And my role was developed. And I have a fairly unique position in the sense that I report to the exec within the ICS, but I also report to the voluntary and community sector reference group as well. So I actually have 2 line managers, one within the SDP, now soon to be the ICS, and one within the voluntary and community sector. So it's a really, really interesting role, and it enables me to have a fairly interesting relationship where I can be on one side of the fence looking over the other side of the fence when it's best to do that. And it's really emancipating and gives you a lot of freedom, which is fantastic. And some of the things there, I just want to really, really whistle through some of the amazing things we've done in Devon, I think, which is really put both the voluntary community sector right at the heart of the ICS, but also that means right social prescription right at the heart of the ICS is we have co-mentoring arrangements. So we have 16 of our senior leaders within both sides of the equation. I have spent a year with each other, 6 weekly conversations around what it's like to be them, what it's like to work in a mad system that is the NHS, what it's like to work in a mad system that is the VCSE, what keeps them awake at night, what makes them happy. And that's really important, breaking down those personal relationships. And it's created real lasting, not just friendships, but also professional relationships, which has made a difference to people at Devon. We have VCSE representation across the piece at the highest possible level. So at the ICS Partnership Board, at local care partnership level, we have the VCSE as part of our recruitment panel for senior leaders within the NHS in Devon. And the VCSE have just taken part in recruiting our 6 non-executive directors for the new partnership board. So they're right at the forefront. What that means in terms of brass tacks is we've around about £6 million of extra funding in partnership with the local sector now as a result of that relationship. We've put money into the sector that we wouldn't have done before, and in just the last 6 months, we've put an awful lot of money into the sector around discharge support, around Pathway 0 and Pathway 1 discharge. From our acutes. That's going really, really well. I'm really chuffed to say, because it was quite a significant investment. 2 years ago, we wouldn't have done that. So again, that burgeoning relationship has really made a difference. We've got community organisations using free space in our community hospitals. In Devon, we have 15 community hospitals, and I was approached by NHS Property Services. What can we do? How can we help you build better relationships with communities? So we've got 3 at the moment hospitals who are providing free spaces for the voluntary and community sector and for social prescribers. One is providing rooms, both big meeting rooms and small individual rooms for things like counselling, for free for the voluntary and community sector, which is a huge savings for them because they've had to pay for that in the past. The second one is providing a community kitchen. So we've refurbed a community kitchen in a community hospital in Axminster, in Devon. And they are delivering all sorts of wonderful things using that refurbed hospital for the community, and that includes getting people together, helping them to with healthy eating classes, but also we've got I know I had the privilege of going to a bakery session run by the local community where people can get together, speak to each other, which is half the battle. The vaccination programme, I mean, I could go on forever about the vaccination programme, massive VCSE involvement, which really resulted in some incredibly creative work with our social prescribers as well. So we worked with our social prescribers in accessing 2 of the mosques in the county. Wouldn't have done that before. It would have been a really interesting relationship, but it would have been a challenging one. But we've got such a great relationship now with the sector that we were able to do that really, really easily, really, really quickly. The creation of a VCSE assembly. So we are now working towards what that means. We basically want a think tank for the sector in Devon that acts as a front door for the ICS, where the ICS can come in, get the expertise, get the people it needs around the particular problems, creating a team around particular issues, but it's an open door. But also that door goes the other way, so it's a real opportunity for the VCSE to talk to the ICS and say, as an equal partner, these are the things that we worry about, and these are the things that we think you can help us with. It's really, really important. And then finally, we're talking about social prescription. Around about 6 out of 10 of our social prescribing roles are directly employed in community organisations, and that's because we have a really healthy relationship between PCNs and the local voluntary and community sector offer. So 6 out of 10, really important. Building on what was already in place, to be honest, in social prescribing, and that's been really, really positive, because we've learned an awful lot around having a hybrid model about what works when a social prescriber is in the voluntary community sector, and what works when a social prescriber is in PCN setting, and as importantly, what sometimes is a bit challenging. So, social prescriptions specifically, we've had researchers in residence working with us for around 2 years from Plymouth University, where they were actually working side by side with social prescribers, with people like me, with the exec group, to talk about what good social prescription could be in Devon. Really, really important, because as I said, we do have a bit of a patchwork delivery mechanism, because we have some working in the sector and some working within PCNs. And what we found was a real spaghetti junction. What a surprise. So different forms of referral criteria, different referral sources, a different asset and a different view of social prescription, with some people, some social prescribers very much performing a signposting service, some social prescribers providing a much more holistic service and having a caseload, almost social work light. Community assets, mixed availability. In some places, particularly in our cities, the community assets were pretty strong, but the more rural you got, the more it was difficult to find Mrs. Jones her salsa class, which she said would make her happy. Those partnership links were really important, but there was definitely a needs gap there between sometimes, if again talk about the yin and yang really around social prescription. If you work in the voluntary community sector, sometimes it was easy to lose connection to your local PCN. And if you worked in a PCN, sometimes it was easy to lose connection with your local voluntary community sector. So those building relationships, as I alluded to right at the start, is really, really important. And then the outcomes, really hard to measure outcomes. I know Dave talked about it earlier around social value, etc. Really, really hard, because we have incompatible data recording systems, and we thought we needed to do something about it. So myself and colleagues from Plymouth University presented this to our exec group, and they agreed to fund the following 5 things around social prescription, which was sustainable funding for community infrastructure, the holidays that travel agents social prescriptors can refer into. Really, really, really important. It's hugely underfunded, we know that. It operates on a shoestring, we know that, and we want it to be a part of the fabric of the offer. We just pressed the button on digital support for social prescribers across the whole of the county, so we're just about to commission a system-wide offer, which is consistent, which talks to EMIS, talks to System 1, talks to voluntary and community sector, can manage case, can do case management, can do referrals, and can do outcomes. Really important. We will support our communities of practice practically to share best practice with each other. We have 7 communities of practice at the moment in Devon, with led by social prescription link workers, who gives them opportunity to talk and to talk about cases, and to just generally just share the load. That's really important. And we're in September, we'll be having a much wider county-wide get together, all under the same roof, where we can cry and laugh and eat together, which is important. Supporting our primary care colleagues, really, really important. Producing a toolkit. It says to encourage VCSE commissioning where that's possible, and where that is probably not unlikely, to ensure that link workers are integrated into the wider practice team and integrated into the wider offer in communities. As I said before, we have 60% working in our VCSE. It's not necessarily the right model for everywhere, but where it works really well. But where primary care made the decision that it's not for them, then we need to make sure that those connections are made, and we want to produce a toolkit for primary care to make sure that's easy. And finally, and something we haven't done as well as we could have done, and it's amazing, is that we don't talk to social prescribers about the incredible intelligence they're getting on a daily basis about what it's like to live in Devon, what it's like to live with health inequalities, and what it's like to live in the communities in which we serve. Really important that we work with social prescribers on that front, because they are frontline workers for us, and that's massively important. So I guess what I would like to finish with really is, if I can get out the thing, which I can, which is good, is I think great social prescription is all about relationships. It's about the relationship between the social prescriber and the patient. It's about the relationship between the patient and the community. It's about the relationship between primary care and the voluntary and community sector. But I think the most important relationship at all is about that key relationship between great health and great happiness.
Well, thank you very much, Darin. And I think, as you can all see, this is a man who doesn't sleep at night. And he has been almost uniquely responsible for bringing us all together, primary care, local authority and the voluntary sector, and creating those relationships, which do require time, as you say, Darin, over the last 2 or 3 years, that have led to some of what he's been able to talk to us about today. So, really excellent presentations. Thank you all. I think we'll go on till 10 past, because I'm now going to hand over to Sam, who's been tracking all your questions and who's going to now lead the Q&A session. Over to you, Sam.
Thanks a lot, Mike. Fantastic presentations. 6 themes that come out of the questions and the presentations, which I think maybe the speakers might want to address in the next 10 minutes. The first one is variability. And there's variability whether it's by age. So, for example, what about children and social prescribing? So where are the gaps in the system of social prescribing? And then the variability around the country. So Darin has persuaded us all to move to Devon. But actually, dashboards, for example, quality improvement dashboards, should we be creating them? How many charities, you say the highest number virtually in the country in Devon, should we be producing dashboards that show differences in different parts of the country, not as a performance management tool, but actually we know that really helps in terms of quality improvement. So that's the variability theme. There's the research theme that Ian talked about, which you might want to come back on. Both the positive research of showing not just the benefits of social prescribing, but also I think very specifically to the commissioners, how you are going to save their money. You know, can you have an effect on the waiting list? I think, you know, you need to be doing research which is very similar to the blood pressure research, which shows those sorts of outcomes. But maybe you might want to talk also about actually putting pressure on the biomedical model. Antidepressants doubled prior to COVID. God knows what's happened during COVID. I mean, Mike and I will tell you massively increase. And unnecessary operations. In other words, wherever you look, there is 2 ways you can approach research. One is to challenge the biomedical model, which is probably 20% of healthcare, but also the positives. Next one is green. Actually, Lee Madonna, who's a very senior civil servant and is running the Net Zero program, has a committee specifically on social prescribing, green social prescribing. It's quite extraordinary, the impact that there is around government. But what more on green? So Ian talks very much about the importance of green and anchor institutions. In other words, tying it in with some of the other priorities. Use for states, Darin talked about that. So you might want to respond to how could estates be used more effectively? There is just tons of empty and underused estates in the NHS. How could they be used more effectively? Then finally, there's something around funding. So the Mental Health Trust in our area put aside 1.6 million for grant funding to to voluntary sector organisations, and they help them in the process. In other words, you don't just land the voluntary sector with having to produce tons of endless documents. They're helped to apply in the process. So actually, how do we spread that across the whole system, which finally ties in with Darin and the ICS? Ian might want to respond to that. I used to use the word infect, but post-COVID, how do we infect people with social prescribing? But I think you come up with other words today. But the question is actually, how do we Darinify every ICS in the country, so that not only are they bought into this wider social determinants of health, but actually they're actively looking at how they can use their budgets with the local authorities much more effectively. So those are some themes I picked out from the questions and what you've said. And what I suggest is, because we've got such short time, should we go Ian, Darin, and then Merron? Ian.
Well, I won't pick up all of them because there won't be enough time. Just one thing straight off is that there's a real opportunity with the creation of the new statutory ICPs and ICBs, the partnerships and the boards. I think the opportunity is that we'll have a set of leaders, some of whom are new, and there's a real opportunity to think about how do we properly market to and induct them in the conversations we've just been having. And I think that's a big opportunity, bearing in mind 1st of July start date. But I think there's a mixture of things where we can contribute a bit nationally to solving some of these issues, including what more we can do on dashboards, on green, on funding with the national lottery. I think a lot of it is going to come down to local leadership. And the one other thing I would be keen not to lose is that sense of, actually, let's not just embed this in VCSE, primary and community-based services. And the estates is a nice example of this, Darin, where you pick this up. Actually, the huge opportunity of engaging all of our other colleagues, particularly in the hospital sector. Thanks.
Yeah, I'd echo that, Ian. I think I think we can afford to be really creative and ambitious around social prescription and our relationship with communities. I think I'm really lucky that the chair in my ICS is incredibly progressive, and she has a lovely phrase around finance follows belief. You have to have the belief first that you're doing the right thing. If you've got the belief you're doing the right things, those relationships will form, and then the money will follow. But you have to build on the foundations first, and those foundations are almost always individual relationships.
Thank you. Thank you. Can you hear me? Just all gone very quiet. You can, good. Thank you. I just want to pick up on the question: how do you Darinify every ICS? How does this work? Well, I think relationships need to be a theme as well here, because the NHS is not known for its focus on relationship building. And we did a piece of work on primary care networks. How can primary care networks be successful in addressing health inequalities? And we identified 3 barriers that are all relationships barriers, and they're about the language and the language of relationships is not built into the system. The capacity is a problem, and the money is a problem. And one of the clinical directors, in relation to capacity, she said, it's enjoyable working with other sectors, and you have to be in those conversations and in the forums for all the other solutions to emerge, but capacity is a problem. And another person said relationship building is not costed into the model. And we think it needs to be costed into the model. It needs to be seen, this activity of relationship building. It takes time, it takes skill, and it needs to be costed into the model. And the solution that we put in that report was to add to the ARRS, Additional Roles Reimbursement Scheme, this possibility of having what we call then a strategic relationship development lead, someone like Darin within your PCN, or maybe shared by a number of PCNs. I don't know how many of these people we need. We think probably 1 per PCN is good, to connect with all the other partners, and also perhaps allow the flexibility within ARRS to allow PCNs to employ community development specialists as well, where that isn't happening already in a place through local authorities or housing or other players, or whether it's not happening to sufficient degree. So what we're looking for is for the ARRS to become more flexible and to be able to appoint more different types of roles, including a Darin type role. And I think that that is really important. Unless we get the relationships right, then we won't be able to move. We won't be able to do all the other things. So that's what I think it does need to be a focus here, to be able to enable primary care to really properly connect with the rest of the system and to play its role fully in this.
Merron, thanks very much. Any final very quick thoughts from the speakers? No? Okay, well then over to you, Mike, for the thanks.
Well, yes, I mean, thank you all. What a really inspiring session, and leaves me with real hope for the future, because, you know, we've heard from the very top all the way down to the very bottom. Well, Darin, that's very unfair on you, but down to Devon. And there is a real connection in the rhetoric, and I see a real way forward. You know, I have to say, you know, with ICS, move to ICS, I did see challenges. I just wondered where social prescription was going to fit into our, you know, traditional models and ways of thinking. But I really see how it can happen. And thank you all four speakers for giving us that inspiration, and also the key to the door to the future. Thank you very much. And I'm sorry for having kept you all from your lunch, but we're now going to have a lunch break, and then we're going to meet for our parallel sessions again at 2 o'clock. But can we just give some silent applause to our speakers as we go?
Thank you.
Thank you.